Research is the cornerstone of advancements in the treatment of MS. Dr. Mark Friedman and Don Carl, a research nurse specializing in MS, discuss the importance of clinical trials and the heroism of patients who participate in them.
Hi, my name is Don Carl. I'm a registered nurse and clinical research coordinator at the Ottawa Hospital, Department of Neurology, specializing in multiple sclerosis, and I've been a clinical research coordinator for the past 17 years.
And my name is Mark Friedman. I'm a professor of neurology and a neurologist at the University of Ottawa, a senior scientist at the Ottawa Hospital Research Institute, and director of the Multiple Sclerosis Research Clinic at the Ottawa Hospital General Campus in Ottawa, Ontario, Canada. So you know, Don, in our waiting room, patients all kind of start talking to each other. And we have our mainstream regular MS clinic patients there that are doing whatever they're normally doing for their visits. But amongst those are also patients that are in our clinical research trials. And they start talking to each other. And they go, well, how often do you see the doctor? And what are you taking? They're all questioning clinical research and the attention that is applied and differences between, say, what you do as a research coordinator nurse versus our other nurses that are doing the regular care. How do you explain this to the patients?
It's quite different, actually, when you put it into that perspective of the regular clinic opposed to a research clinic. We're blessed in research because we have the ability to spend more time with our patients. The regular clinics, our clinic has over 3,000 patients. It's difficult to get specialized care when there's that many patients. The nurses have a lot more to deal with. So in research, not only are we able to provide different options for our patients for potentially an MS therapy basically that would not be available to the regular research patient, clinic patient, we're able to provide different options for those patients. But I'm going to say the biggest difference is the specialized care that a research patient gets as opposed to a regular clinic patient, and a close relationship. Wouldn't
any patient want to be part of a clinical research trial if you're getting all this VIP kind of attention? Or are there certain patients that would be, say, appropriate for these trials? Like when you sit down and try to explain options to them, if this is a therapeutic trial, we have many different types of trials. If it's a therapy trial and there are appropriate therapies available to these patients, they have to go through the regular clinic first, and they have to be apprised of their options.
Right.
But what we may be doing is testing a newer drug. So how do you position this newer therapy or newer potential therapy, because it's risk, right? There's no guarantee that these things work. How do you have this discussion with the patient?
Well, I think the biggest thing for myself as a research nurse is information is powerful. So we need to make sure that these patients, when they're coming into the clinic, that all their options are laid in front of them. And some of these patients don't have the ability to pay for the drugs that we're giving them options to take for their specific type of MS. So we have the relapsing remitting, we have the SPMS, we have the PPMS, we have RIS. There's so many classifications of MS in terms of the treatment options that are available are sort of linked that way. So
but there's risk, right? So
there's an absolute risk for sure. You're asking a patient to donate their time and potentially their health, a lot of blood, and MRIs and other sort of tests we're poking and prodding. So
it's onerous. It's onerous on a patient.
Absolutely.
And then you have to go over the potential risks, don't you? Because they might draw on this new therapy, and all the risks have to be put forward. So obviously there are pros and cons. You've given us a lot of. How do you position the pros and cons? Do you start with the cons? Do you start with the pros? How do you? You're not trying to sell them the trial because that would be unethical. You have to position it in a fair way.
Well, I think the way you position clinical research to a patient is to individualize it for that patient. Every patient has a story. Every patient's disease is specific to them. It's their own disease. We don't try to blanket statement what their MS is to them. So you have patients who are in different stages of their lives. You have different patients who have the ability to give the time for research, and some don't. But you want to position themselves, give them the most information all the information that they need, and the choice is ultimately the patient's, but we have to provide them the options of what's available to them. And why do they go into clinical research? There's many reasons why patients would choose to go to clinical research. Maybe there's a drug that's not available for their specific type of MS, and they're willing to take or do anything.
But they could get a placebo.
They could get a placebo. I mean, placebo-controlled trials are not as big as they used to be. There is an ethical component to that as well. But when you don't have an option for a patient, being in a clinical research trial and they weren't going to take anything anyway
That's an option.
Is an
and
option.
we try to balance it too, right? So even in a trial where there's a placebo, we try to put more people into the possible treatment arm, like a 2-to-1 or a 3-to-2
Absolutely, yeah.
randomization.
The odds are always in favor of treatment as opposed to not treatment. And the thing with placebo-controlled trials, especially like let's use the SPMS population, we're looking at shorter time frames for that placebo-controlled phase. Whereas, years ago, it could have possibly be a 2-year placebo-controlled phase. That doesn't happen very rarely anymore. So we're looking at, a 9 to 12 month, and then usually they flip over to open label. So the time in is not as great as it used to be, but you also have to look at that these patients have first access to potentially
sometimes years before the
really
therapy.
great drugs. We've seen so much happen in the last 17 years in our clinic. So many new treatment options became available, and some of our patients were the first ones to be on these drugs and still continue to be on these drugs successfully. So,
But not every patient's appropriate for a clinical trial. You sort of alluded to it. The individual patient who maybe is a young woman planning pregnancy or something, that's not maybe an appropriate patient. So
it is not.
As if I refer a patient to you, I'm looking at the inclusion and exclusion criteria.
Right.
And I'm checking them off, but I don't know if they're really appropriate or not. You're the one who's going to sort of go through the list, and so how do you do that?
So in clinical research, like you said, there are boxes that need to be checked. There's inclusion, there's exclusion criteria, and not everybody fits those boxes, which is unfortunate. There's age criteria. Those are set forth for reasons. Those are safety parameters. They want to get the same type of patient population to have the most successful outcome. So you want to look at the most efficacy of a drug, but you also need to see the safety of the drug, and those parameters are set forth because of that. But there are patients who don't fit in those boxes for those clinical trials, but they
may still benefit in the end.
They may still benefit in the end, absolutely. And the great part is that it's not just drug trials. So they may not fit the drug trial boxes, but they may actually fit into other. We do lots of cognitive trials or questionnaire trials. So patients can get involved. If they're in the waiting room, like you said, and they're chit-chatting with other patients and they're talking about, hey, you're part of research, I want to be part of research, just because you don't fit that box doesn't mean that there's not something else that you can help.
How do you judge the enthusiasm? And you got to get a sense that this patient who you go through those little boxes with all the X's and they have to come to all these visits monthly or have X number of blood draws. How do you sort of get a sense that, this is somebody who's either going to do this enthusiastically or maybe not, and if they're not, well then maybe they're not appropriate for research?
I think that comes in to the time you spend with the patient. So you're
up front, you mean?
Up front. It comes up front, and I think it depends also where you're approaching patients in the clinic. Were they newly diagnosed? Have they been diagnosed for 20 years and they've never been on a treatment? Are they, 25 to 35 and they're just wanting to start their families? Like, being able to spend the time with those patients and deciphering what the important things are in their lives, and then we decide whether research can fit into their lives. Because if it doesn't fit for what they're buying into, then it's not going to fit.
Okay, this is a hard question.
Okay.
You mentioned SPMS, that's the progressive trials. And we know that if the therapies at best are going to slow things down, if everybody's getting worse in a trial, but some patients are getting worse less quickly, how do you maintain the enthusiasm of these patients to stay in the trial when they suspect, well, I'm getting worse, I can't possibly be on the therapy?
That's a hard one.
I said it was
That
a hard
was
one.
a hard one. MS patients are great. These patients that sign in for clinical research, especially the SPMS and the PPMS population, they may not directly benefit from the treatment that we're giving them. They may not benefit at all. They may be the ones that are coming and going, wow, Dawn, I feel like I'm getting worse. But in reality, they're part of something so much bigger. These patients come in and they donate their time and they donate their blood and their brain scans and their CT scans, and they're committed. And that information may not directly benefit them, and they know that. But the information we're obtaining in clinical research may directly benefit the future of MS and the future treatments of MS. And that's why they do it. That's why they continue to show up for their appointments and do all the things we need them to do, because they know that they're part of something so much bigger.
When we first started doing research years ago, one of the first things that people noticed were that even the patients in the placebo trials, a placebo arm of the trials, did better than patients who were not part of clinical research. Just being part of a research trial with all the attention and such that we give them seems to benefit them. Do you agree with that?
I absolutely agree with that. Research has the ability to have major multidisciplinary approach to MS care. And that care is something that we can't give them in the clinic due to time constraints and finances, and patients don't sometimes have enough money to pay for these drugs that we're offering them. So they alleviate the stress of being the cost effectiveness of being in a research trial. There's no cost to these patients. And they, even though they may be on placebo and they still feel better, I feel that it's because they're part of something, that they feel that every bit of information, they may not be on the drug, but we're still looking at their quality of life, and we're still marking their walking, and we're still seeing them more frequently. And they still feel like they're a part of something, and that information that they're generating is completely useful to us as MS care professionals.
Do you feel more fulfilled as a clinical research nurse versus, say, a regular nurse? If you had that choice, would you stay with what you're doing now, or would you come to the mainstream clinic? What is it to you as a clinical research nurse to be able to offer that?
I wouldn't change a thing. I would not. The time I have to be able to spend with my patients one-on-one, you build a close relationship with your patients because we are afforded the time to be able to spend that time with them. And I think you can relate as a physician. When you see a patient once a year as opposed to once every 3 months, you get to know the patient, you get to know their family and their history and their life. And in turn, knowing the patient really well, you're able to build their health care and their support system for them. And I think even though you have your placebo-controlled patients that are doing well, it's because it's a holistic approach to medicine, which unfortunately in mainstream clinic, we don't have the luxury of providing for our patient. So I think when you look at it, ultimately, every drug that's been available for multiple sclerosis to date has gone through a regulated, rigorous clinical trial. And ultimately, the reason why these trials are successful and the drugs we have increased exponentially since, in the last 15 to 20 years is because of the patients. It's those patients that come into clinical research, they're the real heroes of what we do. We may derive the information and put it out there and these drugs get approved, but it's the patients ultimately that donate their time and their everything. They give everything. They show up, they're accountable, and they give us the information in order to continue to do our job. So bottom line, it's the patients in clinical research that are the real heroes, and they're the ones that we give ultimate thanks to for being able to have the jobs we do, and I feel blessed that I'm able to have the relationships I do with them.
And certainly as a clinician, I feel we're able to offer them and go outside the box of regular types of approved therapies. It's very fulfilling to be able to at least try. We may not have an answer for everything, but at least we're trying, and we can say that as a clinic.
Absolutely, and I think the bottom line is they're the heroes, but what we do gives them hope.